Vasodilators, primarily nitroglycerin, also known as nitrile, nitrostat, isobide dinitrate or mononitrate, that's called Imdur, or the dinitrate is Iserdil. And this medication is used for stable angina. What it does is it decreases the cardiac oxygen demand by dilating the veins and decreasing venous return, which is preload. In variant angina, nitroglycerin relaxes or prevents spasm in the coronary arteries, and that helps by providing more oxygen to the myocardium itself. Nursing considerations, like I said, we're going to use it to treat angina. Sometimes we use it to help control blood pressure. It needs to be used very cautiously with any other antihypertensive medications because we have this big vasodilation that happens, and it can cause orthostatic hypotension. It is also administered IV, and that's to control angina that's not responding to other medications. And it's also used to control blood pressure or to produce hypotension if we're trying to keep the blood pressure down. You may see it used then in those circumstances, such as a preoperative AAA where they're trying to keep pressure down, and also used in heart failure. So the side effects that we're going to see in these individuals is they might have a headache. We want to make sure the client knows about that, and instruct them to use aspirin or acetaminophen to relieve the pain. They usually end up getting used to that and the headache goes away. They could have orthostatic hypotension. So talk about getting up, slowly. Don't hop up and get dizzy. They could have a reflex tachycardia, so you want to teach your patient how to monitor their own vital signs. And if they have anything that they're given prophylactic or to treat that, they could be given a beta blocker if they have such symptoms. Maybe not. And then also a good thing to remember about nitrate is there can build up a tolerance to the long-acting forms. So you need to make sure that they have a medication-free time period. If they have a nitro patch on, perhaps they need to take that off at night, whatever they're instructed to do. However, that would not be good if somebody has nocturnal angina. So a nitrate-free period so that they don't build up a tolerance to the medication. Medication food interactions, it can interact with alcohol and have a hypotensive effect. With beta blockers, calcium channel blockers, it can contribute also to hypotension, so you need to be used very carefully. And then also used with Viagra, it can cause a life-threatening hypotension, so you want to make sure that you instruct your patient not to take their nitroglycerin and their Viagra at the same time. If the patient does experience chest pain, they need to stop their activity, rest, do the sublingual nitroglycerin. They can do that 5 minutes apart to a maximum of 3 tablets sublingually. And with known heart disease, after the second one, they need to get on EMS system, call 911, get themselves to the hospital. Like I said, headaches are common. They could flush, pressure drops. Storage of nitroglycerin. It needs to be stored in a glass container and it is light sensitive. So often when you're walking along in the mall and you see those little old guys in their shirts and you see that roll in their breast pocket, it's probably their nitroglycerin or their Tums, one or the other. But it needs to be kept in a dark container and not in their pants pocket because it can't get too warm, and that groin area is warmer than that pocket up top. So you want to instruct the patient to do that, to keep it in a cool room temperature, just not in the groin temperature. Dark, light sensitive. The med's light sensitive, and it needs to be glass because a plastic container will leach the medication out of the tablet and therefore not be effective. Beta blockers, our prototype we're going to use is Lopressor, which is metoprolol tartrate, and that is an antidysrhythmic and an antihypertensive. They have both properties. It decreases the imbalance between the myocardial oxygen demand and the demand by reducing afterload. Typically, we'll see this used for acute MIs. Beta blockers decrease the infarct size and improve short and long-term survival rates. It's also used for angina as well as hypertension. It's used for dysrhythmias because it blocks the conduction through the SA and the AV node. Like I said, with MIs, it decreases heart rate, decreases contractility, therefore decrease oxygen demand by the myocardium. And if it decreases the blood pressure further, which is decreasing the oxygen demand. And also we see it used in heart failure, but it does seem to be related to decreasing the sympathetic stimulation and prevent dysrhythmias. So it has the chronotropic action by decreasing the heart rate, the inotropic, or which is force action, by decreasing contractility, and it decreases the rate of conduction through the AV node. So with beta blockers, we can cause a bradycardia and a hypotension, so we want to monitor for that. We'll hold the medication if the patient's apical pulse is less than 60, and we make sure we call the provider about if that occurs. We cautiously use these with patients who have heart failure, just because they have so much going on. And we want to avoid giving those to patients who have a bronchoconstriction problems, such as asthma. We want to make sure that we don't use a beta blocker, and maybe it should be administered. They should get a beta-1 selective agent instead, because we don't want to cause them bronchoconstriction. So usually it's a contraindication, but everyone's individual, so you may see it out there. What else do I want to tell you about that? Diabetics. It can actually mask the hypoglycemic symptoms for diabetics, so we want to teach our diabetics about that and monitor for any hypoglycemia. What other things? Patients, we want to need to talk about orthostatic hypotension. Sit, lie down slowly. If they discontinue it quickly, it can have a rebound hypertension occur. If the patient has any shortness of breath, edema, weight gain, cough, it sounds like the patient's going into failure. So those are signs and symptoms we need to make sure that the patients know about, so that we can have them contact their physician. It can also cause fatigue, weakness, depression, and sexual dysfunction. Often you'll see patients who are younger patients are non-compliant with taking their beta blockers because of the sexual dysfunction portion. And once again, make sure you teach any of your patients who are on a beta blocker and they have diabetes to make sure that they know the symptoms of hypoglycemia, and not to include tachycardia, because that beta blocker is going to bring their heart rate down, so they're not going to have that symptom. Thrombolytic agents such as streptokinase, which is streptase. Other ones are altplase, which is activase. Retavase, which is retaplase. These medications act by dissolving clots that have already been formed. So these are the clot busters. The dissolution of the clot is accomplished by conversion of plasminogen to plasmin, which in turn destroys fibrinogen and other clotting factors. So this is the clot busting agents. They're used to treat MIs, DVTs, massive pulmonary emboli, and ischemic strokes. We're going to see these in MI patients. It's best if it's used within the first 6 hours of the infarct. When our patients are being considered to get a thrombolytic agent, we want to make sure that there isn't any active bleeding, they haven't had any recent trauma or surgery, they haven't had a hemorrhagic stroke. What else? We're going to consider about peptic ulcer disease is something else. We're going to take care of them by monitoring bleeding times. That would be a PT, PTT, INR, fibrinogen levels, CBC. They are at risk from bleeding from different sites, so we want to make sure our venipunctures are limited, pressure dressings to any recent wounds. We're looking for a change in their vital signs, any change in their level of consciousness, if they have weakness, any signs of intracranial bleeding, that's not good. And definitely we'll contact the physician if we see any of those things. They may have, with strep, primarily hypotension, so we're going to be keeping a close eye on their blood pressure. They can have an allergic reaction to this drug, so we're going to look for urticaria, itching, flushing, typical signs of allergies. Other side effects we'll see is a thrombocytopenia, anemia, and like I mentioned, the serious bleeding can happen from this medication as well. We want to educate our patients about the risk for bruising and bleeding while they're on this medication. Other times you're going to see a thrombolytic agent used is there is a special protocol for that we use it for blocked central lines. So if you have a clogged PICC line, you want to go to your institutional policy and look up what is a procedure for busting the clot off the end of that PICC line or central line and see what is recommended, and it's a thrombolytic agent that's used to do that. Antiplatelet agents are such as aspirin, which is ASA, acetylsalicylic acid, enterically coated. It's known as Ecotrin, clopidogrel, which is Plavix, and these prevent platelets from forming together, which can produce arterial clotting. I like to say that it stops platelet gang activity, no clumping together of the gangs. Other medications under this classification are Persantine, Riopro, and Aggrastat. They are used for, antiplatelets are used for acute MIs, prevention of reinfarction in patients following an acute MI, prevention of stroke, and acute coronary syndrome. Also, you see quite standardly individuals over 50 who take baby aspirin daily just prophylactically. We do know that antiplatelet agents can cause GI upset, so we're going to be monitoring for that. Get the enteric coating preparation for patients. Caution with anyone who has ulcers. A side effect of ASA is tinnitus, or tinnitus, some people say. And that is because of toxicity to the drug. So we want to educate our patients about that. Individuals who are on daily aspirin doses will have bruising, bleeding risks. We want to tell them about that. To take the medication with food, and once again to use the enteric coating preparation. And if they experience any ringing in the ears, to notify their healthcare provider. Glycoprotein 2B3A inhibitors. Integralin is a common one we use this. That'll be our prototype. It's used to prevent the binding of fibrinogen, in turn by blocking platelet aggregation. In combination with aspirin therapy, 2B3A inhibitors are standard therapy, so often you'll see that used with aspirin. This can cause active bleeding, so we want to teach our patient to report any signs and symptoms of this medication and to notify their physician if this is a problem. Okay, diuretics. There's quite a few of them out there, but three big primary categories. We use diuretics to decrease preload, and a loop diuretic, Lasix, Bumex, those are number ones. It decreases sodium reabsorption, increases potassium excretion. The thiazide diuretics, like hydrochlorothiazide or Hyduryl, is the second, and then the third one would be the potassium-sparing diuretics, but such as spironolactone, which is L-dactone. Those are the medications we often see used for cardiac. Nursing considerations for diuretics is that we want to pay attention to our potassium levels and be prepared to replace them. Typically, we'll see some parameters. Potassium has a real tight 3.5 to 4.5 is normal range. Falls beyond that, we get cranky hearts. If we have too little potassium, we have irritable hearts, and if we have too much, we have slow, stupid hearts. So we want to keep an eye on that potassium. With a decreased potassium, we're going to see muscle weakness, irregular pulse, dehydration, and some ectopy definitely on our EKG. When we're giving IV Lasix, we don't want to give it any faster than 20 milligrams per minute. Both the loop and the thiazide, I said, can cause hypokalemia, so we want to pay particular attention to that. Patient teaching, they're going to have to monitor their electrolyte levels because of these medications, so they need to make sure they get to all their appointments and treat electrolyte imbalances. We also want to talk to our patients about potassium-rich foods, when it's appropriate to consume it and when it's not appropriate to consume it. One of the hidden sources of potassium for cardiac patients is sodium replacement. So someone who uses a salt substitute, instead of going off their salt, they think, oh, I'm going to decrease my blood pressure, and I'm not going to be hanging on to fluid as much if I use this salt replacement instead of sodium. And what it actually is, it's potassium salts is what they're doing. So they're cranking up their potassium when they're using that. So we want to make sure that our patients aren't doing that and not using the replacement. We can encourage them to use something like Mrs. Dash. She doesn't have potassium in hers. Okay, anticoagulants. Unfractionated heparin must be given IV. It prevents clots from becoming larger or other clots from forming, but it does not break down clots. It prevents them from forming. Low molecular weighted heparin, which is Lovenox, that can be given sub-Q, and it's used in prevention and treatment of DVTs. We also have warfarin or Coumadin, and that is also an anticoagulant. That's an oral preparation, and it must be given 3 to 5 days in concurrent with heparin or Lovenox to get to a therapeutic level. So they kind of overlap because they work in different parts of the clotting cascade. So we need to build up the individual on on warfarin before we get rid of the heparin. We want to make sure that for heparin, that we're monitoring PTT for the titration dose. So based on what the PTT is that the heparin will be titrated to that. That's usually prescribed by pharmacy. We're going to monitor their platelets, and the antidote that we use for heparin or to reverse heparin is protamine sulfate. That is the antidote to use for heparin. Protamine sulfate happens to be derived from semen. I don't know how they figured this out, but it reverses the bleeding. So the people who have problems with protamine sulfate are men who have had vasectomies because they have built up antibodies to semen, and therefore the protamine sulfate may not work on them. Just a little bit of knowledge to pull out of the back of your head when you want to impress somebody. So that would be the only group of individuals that perhaps would not benefit from the protamine sulfate if they had to be reversed. We want to watch for the hazards of heparin, which would be bleeding, side effects. So therefore we're going to have soft toothbrushes, electric razors, not safety razors. Same with Coumadin. We're going to teach the patients to use soft toothbrushes, safety razors. Teach our patients to look for signs and symptoms of bleeding, pink urine if they have bleeding in their bladder. Venipuncture sites should be limited. They may bruise more. They are at higher risk. Warfarin, it inhibits the synthesis of vitamin K clotting factors, so that makes the antidote to warfarin vitamin K. We monitor that by the PT and the INR, and patients are maybe at home on this for years and years. It's often used with chronic atrial fibrillation patients to decrease the risk of clots being tossed out because of the atrial fibrillation and loss of atrial kick in the atrium where clots could form. So those patients are placed on warfarin. It's also used prevention of venous thrombosis, and like I said, chronic venous thrombosis formation with atrial fibrillations, and also with prosthetic heart valves. So patients who have had valve replacements will also be on Coumadin. ACE inhibitors and ARBs, these are afterload reducing agents that help the heart pump more easily by altering resistance to contraction. ACE inhibitors, primarily enalapril, which is Vasotec, or captopril, which is Capitan, and with the angiotensin receptor blockers, losartan, which is Cozar. Now, if you notice in this slide, I've highlighted the red. As you can see, those classifications have the same last name. So if you see something that's with a pril, you know that it's an ACE inhibitor. If it's a sartan, you know it's an ARB, and they pretty much all act the same way. They can be contraindicated for patients who have renal deficiency, so use with caution with somebody who has a renal disease. We will see, you need to watch the blood pressure with the first dose, because 2 hours after their initial dose, they can have a drastic hypotension. So the very first time you give it is when you really want to pay attention to what their blood pressure is doing post-medication. They can cause angioedema, which is swelling of the tongue and throat. That is an allergic reaction to that, so we're going to pay attention after the initial dose for that. And they do hold on to potassium, so we're going to pay attention to increasing potassium levels. ACE inhibitors can give patients a dry cough, and you want to talk to your patients about that. If they're being harassed by a dry cough, they could be converted over to an ARB, and the ARBs don't seem to have the cough. Let's see. We will also, they could have a decreased sense of taste or a skin rash, and that's with the ACE inhibitors as well. They want to let their physicians know, and perhaps switching to an ARB won't have that problem from happening. They're good drugs. They control blood pressure as well, and they are also using them with heart failure. Let's talk about inotropic agents, primarily digoxin, which is lanoxin, dopamine, dobutamine, which is Dobutrex, milrinone, Primacor. They are also inotropic agents. Inotropic increase the force of myocardial contraction. That's what an inotrope does. This is primarily used for patients who are being treated for heart failure, and it is also used for dysrhythmias, primarily atrial fibrillation. Our nursing considerations are that dobutamine, which is Dobutrex, dopamine, Primacor, they are IV only. Patient must be continually monitored. They are in the intensive care unit or the cardiac care unit. Frequent blood pressure, and we must monitor their urine output very closely. With digoxin, when we're giving this orally, we want to make sure that the patient gets it the same time every day. We take an apical heart rate for 1 minute. We're going to hold if it's less than 60 or greater than 100. We're going to contact the physician if that is such the case. We're going to observe the client for nausea and vomiting and watch for signs and symptoms of toxicity, fatigue, muscle weakness, anorexia, confusion, also halos around lights, vision changes. They have difficulty with night vision. Regular digoxin and potassium levels are required, and we're going to teach our patients to do that. We may need to teach our patients how to take their own pulse and to instruct the client or patient to hold the dose and contact the provider if they fall outside of the parameters we've set. We don't want them to take their medication with antacids. They have to be separate antacid by at least 2 hours because we won't have absorption to occur. Digoxin likes to interact with things, so pay attention to the food and drug interactions. It also interacts with thiazide diuretics, loop diuretics. It increases the risk of DIG-induced dysrhythmias with those. It also interacts with ACE inhibitors and ARB. We have an increased risk of hyperkalemias with that. And it can also decrease the therapeutic effects of digoxin. So we want to use DIG and these other drugs cautiously together. However, they will be used together. You will see it. So we want to pay attention to the interactions that can occur. Digoxin happens to be one of the drugs that has a lot of interactions with other medications. Calcium channel blockers, verapamil, which is Calin, amlodipine, Norvasc, and diltiazem, which is Cardizem, which is spelled wrong on that slide. I'm going to fix that. And that alters the movement of calcium ions through the cell membrane, resulting in vasodilation, which in turn lowers the blood pressure. This is also used for angina as well as cardiac dysrhythmias, primarily atrial fibrillation and atrial flutter, as well as SVT. Another drug is nifedipine, which is Procardia, is in this group as well. We need to monitor our patients' blood pressures, heart rates, their position change, because hypotension is common with these medications, so slowly to get up. And we want to use it cautiously in patients with heart failure, heart block, bradycardia. We're going to use it cautiously. Also, if we're using verapamil or Cardizem, we want to be careful with digoxin and beta blockers with those two, because they don't always get along. So calcium channel blockers can cause constipation, so we're going to teach our patients about high fiber foods. Like I said, bradycardias and AV blocks can occur, so we'll need to teach the patient how to monitor their own pulse. So we're going to teach them how to take their pulse. And we want to avoid grapefruit products because that decreases or changes the absorption of the calcium channel blocker. And finally, I have antilipemics, which are the statins, and this is Lipitor, Zocor, Mevacor, Pravachol, Crestor. These are the statins. And this decreases LDL cholesterol levels by suppressing cholesterol synthesis in the liver, and it also helps produce HDLs. That's the simplification of a very complex mechanism of action. It's used primarily for hypercholesterolemia, so if someone has high cholesterol, it is prophylactic in preventing coronary events. It's used to protection against MIs and strokes for patients with diabetes, and it also helps raise the level of HDLs on patients who have primary hypercholesterolemia. However, these statins, which were once thought to be such a miracle, they have some side effects. Hepatotoxicity, so therefore we want to keep a good line on liver function tests every um, 12 weeks and then every 6 months if somebody's taking these ongoing. We want to advise them to avoid using alcohol, and it also causes myopathy, which is evidenced by muscle aches, pains, and tenderness, primarily in the legs. Now, I went on this briefly and had such achy calves that I forget it. I changed my diet. Anyways, so we're going to monitor creatine kinase levels for patients. We're going to ask about muscle aches, pains, tenderness, and notify the physician. Peripheral neuropathy is also evidenced by weakness, numbness, tingling, and pain in the hands and feet, and that can also be a side effect of this drug.